Welcome back. I'm Doreen Marshall, Vice President of Mission Engagement at the American Foundation for Suicide Prevention. I'm pleased to introduce the presenters for our next session, Care Transitions, the Role of Connectedness in Preventing Suicide. Our presenters for this session are Karen Johnson, who's the Senior Vice President of Clinical Services for United Health Services, and Becky Stoll, who's the Vice President of Crisis and Disaster Management at Centerstone. Ms. Johnson from Universal Health Services and Ms. Stoll from Centerstone have led their organization's development of their zero suicide programs. They have a wealth of experience in the implementation of zero suicide and are here today to focus on the topic of care transitions. As with the previous sessions, we will be taking questions, so you can type your questions in, and at the end of the presentation, I will moderate the Q&A. I'm going to turn it over to Karen and Becky.
All right, so good morning. Well, no, not good. Good morning, afternoon, wherever you are. It is so nice to beam in and see you all. I'm Becky Stoll, and I'm sitting here in Nashville, Tennessee, where it's a nice sunny day in the 60s. Very sad that we can't be there in person in Chicago. Was really looking forward to making that trek up on Southwest Airlines for probably less than $100. Would have been awesome. Particularly bummed out that we can't get any Garrett's popcorn. I told Karen when we were talking about this presentation the other day, that was the biggest pain point for me is I can't get any Garrett's popcorn sitting in my living room in Nashville, Tennessee. So Karen and I are here this afternoon to talk about what really we think, and I think more and more folks are identifying as kind of this bugaboo that we have in suicide prevention care, and that's the transitioning of individuals from one level of care to the next. And so we want to spend a little bit of time and hopefully spur some thought in you all about how we can, in this area where we now know better, that we can definitely start doing better. Karen's going to advance slides for me. So Karen, I don't want to say too much advanced slides. So when you see me kind of, we've done this enough, you go ahead and advance when you feel like it's time, and I'll keep up with you if that'll work. The National Strategy for Suicide Prevention, as you all know, has been a really nice roadmap for all of us. And having an entity around that really fosters this public and private partnership through the National Action Alliance is just really invaluable to the suicide prevention efforts that go on here in the U.S. So we love having that entity around to really advance the national strategy and pull together, everybody at the table that needs to be paying attention to this issue. So there we are, look at us, yay. If anybody's ever liked their headshot, put in the chat that you liked your headshot, but I don't know anybody who's ever enjoyed one of those. So anyway, it's fun. So why are care transitions a big issue? We know that we have these deaths in the U.S. The data is going to come out, and we're going to see this trajectory where they continue to go up and up and up and up. But that really, as we know, is the tip of that iceberg. And when you look under the water, we see that attempts that will require medical care are just, the numbers are astronomical. And so we have a lot of people in the system of care, medical and behavioral health, that are making attempts and presenting opportunities for us to hopefully provide good quality care. But that chasm between our systems within physical health and within behavioral health, in between the two, often, are chopped with pretty rough waters. So we know that this transition from inpatient psychiatric care to outpatient psychiatric care is super dangerous. And I've been so struck by individuals, even in our own field of care, that don't realize that these statistics that you all can read here on the slide, I did an interview with a national organization in behavioral health for a podcast they were doing at the height of the pandemic, and they were shocked to learn that top statistic and how the dangerousness of these time periods between leaving a unit and going to outpatient care. So we have to make sure that this information is on the radar so that we can do something about it and make these transitions just much smoother. So how do we do that? I mean, there's really little buckets of activity that we have to tend to. And I don't think we can view this in silos. We have to view um, inpatient care and outpatient care as one kind of clock unit that's working in unison, and everybody's playing their role, much like we try to do in our own systems of care. You know, everybody plays a role and we all row in the same direction in the boat. And when we do that, we really can make a huge impact. In that middle block, that human connection, you know, that's not only the connection that we're trying to make sure that the person receiving care receives, cultivating that, but it's also leads into that building bridges. It's cultivating the human connection between us as providers. And so that we don't, you know, kind of play in the field like a horse with blinders on, that we really see the 30,000 foot view and how our systems need to work in a real collaborative way. So when we do that, you know, let's talk about, and Karen's going to jump in here, you know, when we looked at this, when the Action Alliance looked at bringing a group of us together to talk about how we could do better in this space, we knew that the two big pieces of this pie were inpatient providers and outpatient providers on the behavioral health side accepting these referrals. So Karen's going to jump in and talk about, you know, really what that has looked like on the inpatient side. And then I'll be back in a bit to talk about how we kind of navigated that on the outpatient side. So Karen, I'll turn it over to you.
Thank you, Becky. And as a way of introduction, I'm sitting steps away from Lurie Children's Hospital and from Northwestern, so in snowy Chicago today, so a little bit different from where Becky is sitting. Becky and I have the privilege of working together on the Action Alliance and have been doing this work together for the last 7 years. I'm also a former CEO of a hospital that's sponsoring this conference today, River Edge, so I'm really delighted to be here. And already the care transitions work that Becky and I are going to speak about for the next few minutes has been the topic of conversation this morning during the conference, and the critical work that came through the Joint Commission, as well as Dr. Mike Hogan, and then again challenged by Dr. David Jobs around the importance of and where the place is for inpatient care. There is a place, and the place is really, I am going to speak to that shortly. I oversee, and Becky will talk a little bit more about herself, I suspect too, but I oversee the clinical quality and safety at more than 135 inpatient facilities around the country. And the need to increase this work because of those statistics and those really frightening statistics that Becky shared is critical. So we're going to share a few of the highlights of the work that we've developed around this. And as social workers, we all know that once an individual is admitted to an inpatient facility, discharge planning is the first thing that we start thinking about. What level of care will the individual require? Is that first very key question. Assisting the individual and the family, and family is defined very broadly. That the care that's being provided in the hospital is really just the very first step in recovery. Building upon the individual's needs and available resources will occur during the hospital stay, but identifying those early so that we can create the treatment team process that happens after hospitalization is what needs to be established. If the individual has an external treatment team already, that collaboration needs to begin immediately in order to share the treatment goals that have been identified by the team and to prepare the individual for a swift and smooth transition to outpatient. Most facilities have what they call, and I'll air quotes here, an approved network outside of those that are approved by the payer, if there's a payer engaged. The connection is strengthened, we know, by establishing a memorandum of understanding or agreement. And what that looks like is key. It should be focused on the sharing of medical records, including transition plans. And I know that Dr. Hogan spoke at great length about the crisis safety plans, but it also should include medication lists and other goals that should be part of the transition. You know, partnerships in this work and communication are really key to a successful transition from an inpatient setting to an outpatient setting. And again, the key to any successful hospital stay, whether it's in a psychiatric hospital or in a medical hospital, is the involvement of the family as defined by the individual receiving care. And in that work, we have a very broad definition of what a support network looks like. And that support network may also need support. And so it's important for us to all collaborate together on this. There has already been this morning in discussion about the necessity of peer specialists and outside support groups along the way, with education around signs and symptoms of relapse and suicide risk, which are critical components of this particular recommendation. How can we engage the people who care for those in care is critical. And for children and teens, although difficult in the age of COVID and the challenge of where kids are getting their education, again, schools and community supports are key. Before the transition actually happens, development of a safety plan is critical. And we certainly have known that safety planning has been key to our work in COVID and even accentuated during the pandemic. But again, this is something just like the discharge plan begins at admission and evolves through the course of care in the inpatient setting. Safety planning is a key component of our overall training, and it should be for all clinicians. That is part of the onboarding to a new facility, to a new clinical care setting. And we also include it on an annual basis just because of its complete import. This is another opportunity to collaborate with the individual in care and their support network. It's critical that you include the folks that are involved in the network around the individual in care. Coping strategies are developed through the course of the stay. The individual in care lets us know what it is that works and then what the clinical treatment team can bring to the table to support that. And at the time of discharge, these critical safety plan strategies are reviewed with all parties. It's key to ensure that not only the individual in care, but that support system is in agreement about the safety plan. And again, reducing access to lethal means. I know that that's been discussed so far, and that will be largely a topic later on in the conference as well. Lethal means is something that we at UHS, but I believe all healthcare providers do, is check first on admission and then recheck and double check and triple check at the time of discharge. We obtain the name of the individual who's going to secure the lethal means. And we use, again, the very broadest definition of what that means, including medications and the medications the individual is discharged with. We typically only supply a 15-day prescription with refills if that works in this transition so that they can get to their psychiatry appointment. And it does become a challenge in certain markets around the country, and we make adjustments as needed. We want the individual to have the first appointment with their psychiatric provider to be before the prescription runs out. We know that readmissions are generally related in some form or fashion to an individual's lack of access to their medications. And so that's critical for the components of care. And the next component of the transition is the connection to the outpatient provider like Centerstone. It is a best practice standard of care to schedule an outpatient appointment prior to discharge. Seems sort of obvious there. When at all possible, utilizing step-down care is critical, meaning offering an intermediate level of care, such as partial hospitalization and IOP services, prior to a traditional outpatient appointment. In the age of COVID, that's been done in large part through telemedicine and telehealth. And we, as other providers have established a significant telehealth platform to connect individuals to treatment, which has increased our compliance in this transition time by greater than 15%. These connections need to happen in this manner. And when we own the system of care, that connection can occur. We don't own a lot of traditional outpatient services. So the time that a patient leaves a structured 6-hour or 3-hour a day program is the time that we would connect with a traditional outpatient provider. Again, the important piece here is that our clinicians use the established network that at each location to assist in making that transition smoother. After discharge, following up with the patient and the outpatient provider is key. The sharing of the medical records, including the safety plan and the medication list, are required documents that we share, not only by UHS and other health systems across the country, but it's also one of those pesky requirements from the Joint Commission and CMS. We do it first because it's the right thing to do by the patient, but we are measured by our capability to do this. And it's important, I know that Becky will speak to this. Becky's work in the outpatient network is nearly impossible to do without the information that comes from an inpatient setting. In addition, follow-up calls and caring contacts are critical. Leaving a hospital is such a risky time. Don't need to say that any more than what has already been said before Becky and I even shared the screen. Providing hope that recovery is possible with the caring contacts is critical. I will share just a couple of things on this final slide before I transition back to Becky. When we have the network inside of our organization, building it out is critical. We have assigned sort of step-down navigators to assist individuals in inpatient to make that transition, to speak to why attendance in the program is so critical. Those folks attend inpatient treatment team meetings to be the bridge that we illustrated earlier between the inpatient providers and the outpatient providers. What does it mean to plan for discharge? What does it mean to leave what is a safe environment in most settings, right? To continuing care is critical. And it's also important, if possible and when possible, that our clinicians on the inpatient setting can connect with the outpatient clinician as well and assist the individual in care, the patient, to make that connection prior to discharge. Developing the rapport that will allow that transition to occur safely is key. I'm going to, in the spirit of transitions and how we do things, I'm going to turn back to Becky so she can speak to what happens after the hospital stay.
Great, thank you, Karen. And I apologize. This topic excites me so much and I feel so passionately about it. And I also got distracted by my Garrett popcorn thoughts. I forgot to introduce myself. So I'm Becky Stoll. I am the Vice President for Crisis Services, Suicide Prevention, and Disaster Mental Health at Centerstone. We're a multi-state behavioral health company in and outpatient. So just let me clean that bit of stuff up. So let's talk about the outpatient side. You know, Mike I didn't see Mike's presentation this morning, but I know oftentimes when we're talking about this, there's often a Swiss cheese slide. I don't know if that Swiss cheese slide made its presence known this morning, but it's a Swiss cheese slide that shows Swiss cheese and where the holes or where people can fall through. I've really taken to thinking about this since we've been doing so much work over it over the past few years, is thinking about the roads of mental health. And the roads of mental health care are fraught with Swiss cheese holes. And if you know how to navigate it, it's still a very difficult system to navigate. So when we have these individuals, and you know, Karen's done all the great work that she and her crew do on the inpatient side, we have to stand at the ready to receive that referral, and that it happens as smoothly as a pass from Patrick Mahomes to Travis Kelce, and it's smooth and it's not complicated, and we get the desired outcome. Sorry for I'm not a Chiefs fan, but figured everybody would know who that is. So we often, you know, we have a new baby in our family as of a few months ago, and I'm reminded when you hold her and you pass her from one person to the next, you really have to hold her spine and her head. You know, we never would just kind of toss her to someone, and it's taken that special care because of the fragile nature of her. And I really think this is the same. We have to think about these transitions, I think, in a much more robust way than we have in the past. And I really challenge all 500 plus of you that are on this call to really look at your systems of care and grade yourself on how you're doing in this space, because my suspicion is we all haven't been doing as good a job as we can. So it's imperative of us to reach out to our colleagues, inpatient, outpatient, and really get to know each other. And I love the third bullet here, that we're all accepting this shared responsibility, that we're going to navigate people from A to B and B to A together. In our system, we did that with MOUs, and we met regularly where we all agreed on what the shared responsibility was going to look like. And we would show up at those meetings with metrics and say, you know, we agreed to do this, you agreed to do that, and kind of here's how that's going. And that was incredibly helpful to not only let people see how they were doing, to let us see how we were doing in terms of holding up our commitment, but also to hold each other accountable. And look at our colleagues and our competitors and see how they were doing. And if other people could do it, why couldn't we do it? So I think a little friendly competition in that space helped too. But it's really active, purposeful outreach to our colleagues to do this work. The other thing is when we, you know, can meet this number two, this having some type of interaction from the outpatient provider to the person while they're in the facility is just a real given. But this one is hard. It's hard from a billing perspective, you know, on the outpatient side, having the bandwidth to be able to go and meet these folks. So can you do that in a virtual way? You know, I view it in our system, when we try to create things that are tough, I look at it as the Old Navy, Gap, Banana Republic. Okay, if you guys don't know, they're all owned by the same company. And you can get a white t-shirt at Old Navy, you can get a white t-shirt at Gap, and you can get a white t-shirt at Banana Republic. They're different quality, they cost different. So I always, you know, if the best we can do is sell an Old Navy t-shirt, then that's where we start. So what does the Old Navy t-shirt look like where I can have the patient who's coming to see us for outpatient care somehow know or meet or hear about who they're going to get on the other side when they get to this land of outpatient care? And then how can we work up to, you know, Old Navy's fine, but now our shirt's a Gap. And we do this a little bit better because what we try to avoid here is what used to happen, where the inpatient hospitals would call us for 10 discharge appointments. We would give them 10 discharge appointments, and then they would go back and, act like Oprah. You guys have heard of Oprah, right? You're in Chicago. It would be just like, you get an appointment and you get an appointment, and they would just go back and disperse these appointments, never talking to people about, could you show up on a Tuesday at 10 o'clock? No, I can't. I've already missed a week of work. And like no coordination around these. So the more you can do in this number 2, to try to figure out how you can make this happen, the better. So how can we do that? I love this idea of narrowing the transition gap. We have to step forward on our side and make sure that these folks are of the highest priority, that we have appointments available to them, so that we don't go, this is great, yes, we'll take your referral, and we can see them, even in 2 weeks. You don't want to do that. And you also want to make sure that the provider who's going to see them on your end is competent, confident, and skilled in suicide care. Can you imagine on the physical health side, if I went to a physician and had a medical condition, diabetes, let's say I had that and my doctor referred me to someone for that care, and they had no training or specialty in that just would never happen on the physical side. So we have to, I think, raise our game on the behavioral health side, and schedule these folks, and it takes a lot of work. Schedule these folks with people who are competent in suicide prevention care. And Karen's talked about, making sure that we have circled their wagons while they're inpatient, and that we continue to do that on our side. Anywhere that we can insert that peer support, whatever level that looks like, is fantastic, so that people can meet with, go to a group, talk to someone who's walked that walk. I also challenge you to go back and look in your systems, because how do you know if this particular population of individuals has not shown up for an appointment? And this is a real dangerous area, where you could have people being admitted, getting appointments for care in an aftercare situation after a suicide attempt. Do you have anything in your system that alerts you and lets you know that these people have not shown up for this appointment, so that the alarms can be sounded and we can reach out to them to make sure in real time, to make sure that they get another appointment, or why they couldn't show up to that appointment, help them problem solve. We built functionality into our system so that we would know if this population in real time was not showing up for an appointment, so then a subsequent action could be activated. So how did we, what did this look like for us? So we, fortunately, we are grant recipients just like you all. We utilize hospital liaisons in our system. So we have a group of individuals that are employed by our organization that go into inpatient psychiatric units. That's their office. And they work with the unit to liaison people back and forth. That was the beginning of what our GAP t-shirt was going to look like. And we said, if we had somebody going into the hospital working in tandem with them, who could say, even if our clinician couldn't go visit them or beam in via a video, that's where we started. At least they could tell me what Karen Johnson's like, and that she's good people, and that's who I'm going to see, and do I know how to get there, and all those kind of things. When we really ramped up that kind of intensive outreach and did follow-up care to make sure that people weren't falling through those Swiss holes, we did this within a grant that we have. In the initial 30-day look that we would do with people, we had nobody take their lives in that. And we saw the recidivism to emergency departments, the need to go back, really plummeted. This was emergency department visits where we transitioned. We saw it drop to about 8%, which was great. People were getting the care they needed. But the other is we looked at, did this save healthcare money? And what we found in the first study that we did, taking out the amount of money that we needed for staffing to do this, we netted the healthcare system just about $400,000. When we got that grant a second time and we went all in, and I would say we probably raised it up to about a Gap or Banana Republic t-shirt, maybe not Banana Republic, somewhere in between. We saved healthcare $2 million. That was after all the cost of running that kind of intensive follow-up for care transitions. So not only was the care better, but it saved healthcare a whole lot of money. And we knew that, you know, how could we transition and make sure some of this information is something that we paid attention to and make sure we try to do things in a better way. So I know we're going to a Q&A, so I will stop there. There's Karen, there's myself. And if you have any questions, we're glad to field those in the, I think, about 10 minutes or so that we have remaining.
Thanks, Karen and Becky. It was a terrific presentation. I learned so much. We have a number of questions, so I'm just going to kind of roll through what we can here. One question that has come up is asking for you to talk a little bit about the role that peers and peer support can play in care transition planning.
I mean, I think they can be a vital, almost hinge pin to the whole system, because not only can they be employed in both settings, but I think they can provide the conduit that we're looking for, and it can be positions dedicated to that. So when you have the human capital in those individuals that you can deploy from one side to the other, you know, whatever that direction that looks like, and it provides someone who's been in this person's experience, I think the value of that is just almost, you can't put a dollar amount to that, and you can't put a quality amount to that.
And I think too, I would say, Becky, as well, the value of the arc of the treatment course, right? So unfortunately, it's not like taking an appendix out. Once you take the, you know, ruptured appendix out and you have a couple of things medically you need to do, somebody who suffers from suicidal thoughts and intent and plan isn't something that can get fixed quickly. So the peer support specialist can also then say that treatment over a course of time, there's great value in it, and stay with it, and provides hope and certainly resiliency to the process.
Thank you both. Another question and comment that have come in, the person is asking about this idea of transitions between inpatient and outpatient, and kind of what can be done for outpatient facilities that have a no-show provider drop penalty. And the question is that a contributing factor for people who fall through those Swiss cheese holes?
Yeah, I mean, I think we have to get away from kind of putting people on naughty lists. You know, we're asking people who have brain conditions, who are struggling and having a hard time, to do things that are tough. And so I think we, you know, as much as we can do things to foster getting them to want to come, and not only wanting, but the capacity to come, you know, what's preventing them? Is it their illness? Is it social determinants? What is that? I think our efforts are better spent on that than getting sent a "you suck" letter and now you can't come back, you know, and putting them on some kind of naughty list, or you can't come here. That doesn't seem to be the best use of our efforts.
Another question, there's lots of questions around this idea of what we can do post-discharge. And one of the questions has to do with access to antidepressants. And I guess the wonder about when a person is discharged with, say, a month of medication, kind of balancing suicide risk versus knowing that you want the person to stay on a medication regime and making sure they're discharged with enough medication. So can you speak a little bit to that, kind of the discharge planning around medication and how to ensure the person has access to what they need while also balancing with suicide risk?
I think I mentioned some of the challenge, right, is the connection to the psychiatric appointment, whether it's with a licensed nurse practitioner, mental health nurse practitioner, or if it's a psychiatrist. Securing that appointment tells you how long you need to be providing the medication. And again, the safety concerns are great. We'd rather give less number of days and more refills than a longer term, a 30-day, a 60-day, a 90-day supply. And this is one of the, this is in Becky's Swiss cheese model. There's a pretty big hole in the Swiss cheese when it comes to access to that level of provider all over the country, let alone here in Illinois, right? And, wherever all the other participants are. And that's one of the crises of the system that has to be fixed, so that we do have adequate space in networks. And I use the network, whether it's a payer network or another network. But we look at smaller, more refills, less pills, to get to the point of the appointment.
Great. The next question, lots of thanks for your presentation, folks, really enjoyed it. The next question has to do with family involvement at the inpatient level. And I'm just going to read what the person here wrote. The idea that families are involved at the inpatient level is an ideal that's rarely handled well due to little training of hospital social work staff and suicide-specific care for families. Then when a patient gets to outpatient treatment, but what about family treatment? Is that the Banana Republic t-shirt?
I think that is the Banana Republic t-shirt. The Banana Republic part is probably has a lot of tentacles to it. And Karen can chime in on the inpatient side. But this is a time to circle your wagons. I understand a lot of people don't have a lot of wagons to circle, but we have to be, I think, purposeful about really sniffing that out a little bit more, so that we're including people. We're not with these folks 24/7 once they're out of the hospital. And when you're with them, in the hospital, it's not their reality. So I think as much as, we can pull that in, I think the better.
And I would say on the family side, one of the things that we're always the most concerned about is if there isn't a support person support person family, that definition is broad. We need to broaden it larger than actual family members on a family tree. That if an individual is struggling to have that level of support, that's a risk. And that is a clinical discussion with the clinical team to make sure that we have, we've reached deep enough into the bench, if you will, to ensure that happens. But it is a challenge. It's a challenge in a short-term stay, but it's critical that we, do as much as we can around this. And then in the crisis safety plan, it's not only for the individual that's receiving care, but it's also for signs and symptoms and education and support for the family. So our practice has been to engage them in what supports are available for them as they care for and engage with their loved one.
I'd like to thank you both, Becky and Karen. We are out of time for this session, but this has been a great discussion, and certainly I'm sure attendees will take this information into the rest of the day and moving forward. Thank you both.
Thank you very much.